So, welcome to our Essence of Medicine podcast. Today, we are going to talk about something obscure. It's called OLLIF. So, what does it stand for?
Oblique Lateral Lumbar-Interbody Fusion.
But not only that, oblique lateral posterior lumbar interbody fusion, because it's 2L and it's a. Dominic, what do you understand what the OLLIF actually is? What is OLLIF?
It's a minimally invasive fusion technique where you take parts of the lumbar spine and you fuse it together with minimal incisions and minimal OR time in general.
Now, people who have back problem probably have heard about common treatment for the spine, but let's talk about it in a way that brings it to attention of the people. Do you have back problem yourself?
Sometimes, but not nearly as much as our patients.
Yeah. What about you, Mitch?
Fortunately, not really. No.
No. Do you know somebody who has back problem?
Who doesn't?
Who doesn't? That's perfect. Why is it a perfect answer? Because by the time you're 50 years old, there's only 30% chance you don't have spine problem. By the time you're 60 years old, there is 5% you haven't had spine problem. By the time you're 70 years old, there's only 1 to 2% chance you haven't had spine problem. So this is a very common problem. So who hasn't? Now, if you're 20 years old, probably you don't have spine problem. So it's a problem of the advanced age, but it's a very common problem. Now, when you have a bad problem, the chances are 9 out of 10 chances are the problem is the disc that our spine is made of bone disc. The chances are made that the disc is the problem. So what is the function of the disc, Dom?
Oh, it's a wonderful cushion. In fact, I'm going to steal an analogy from you. I hope you don't mind. At least I'm giving you some credit. If you've ever seen a car, they have these wonderful things called tires that separate them from the road. And they're pretty much the same cushion in your spine. So that sort of tire in your spine takes a lot of the vibrations throughout the day and all that pressure and just kind of keeps things a little greased, if you will.
Can you imagine that if you didn't have the tire, you would drive on a car that didn't have that rubber tire that is filled up with air? Our discs are not obviously filled with air. What are they filled with?
Oh, they have a little fluid inside.
Jelly-like material, but the outside is really tough.
Hard annulus, yep.
Hard annulus and soft inside. Now, what is a typical pressure inside of your car, Mitch?
Like a tire PSI, about 35.
35.
PSI.
What do you think was a regular PSI that a disc can take?
Can I borrow a vowel or because I would go with 40. I like the number 40. Solid.
Somewhere between 60 and 90. Twice to 3 times more than your car. That's how much it can take.
Wow.
But your whole weight has to be carried by the disc at the end of the day. So the capsule is extremely tough. Inside is jelly that distributes the pain and the pressure. But then the problem is that, have you seen a tire that drives 70 years? No. It's a rare thing that the tire, and so is our disc. So that now all of a sudden it makes sense that you're good. By the time you're 50, 70% of the people have problem. By the time you're 60, it goes to 95. By the time you're 70, 98, 99% of the people have the problem. Now, many times we just support you and you don't need a surgery. We do physical therapy, we do injection, we do steroid. We just quit doing that horrible things that, like going on trampoline or things like that. We quit over stressing the spine. Often that's enough. Sometimes that's not enough. When it's not enough, there's 2 possibilities. You have a flat tire that has one hole. Or you have a flat tire that the rubber is gone and it's slashed open. These are the 2 ways that you have a problem with this. Now, if there's one hole and part of that jelly is coming out, we call it herniated disc, and then you have mostly pain going down the leg. And the solution for that is, what do we do for that?
So we can just take that little part of jelly out.
Microdiscectomy. Yeah, and you can do it with a microscope. You can do it with endoscope. As a matter of fact, we have a some really good surgeon coming up in our upcoming so-called Campaign Society meeting who will talk about that. But then sometimes you have a tire that has 20 holes and the rubber is gone. It's smooth as you can have. Do you feel safe driving that tire? Probably not. So what do we do in that case, Mitch?
We do an OLLIF.
No, we do a fusion. But
Sure.
there are many ways to do a fusion. Now, the idea of fusion is we take the bad disc out, we put a spacer in to keep the space open. Why do we want to keep the space still? Why don't we want the bone on bone?
Well, if you don't have that appropriate distance between the end plates, between the two vertebrae, you have collapse around the foramen, so where the exiting nerve root comes out.
Between each two bone, a nerve is coming out.
Then you have compression on the nerves, radiculopathy, all kinds of problems.
Yeah, so you have one nerve coming between each of those two bones where the disc is. And if the disc is gone, the bone collapses and that can push on the nerve. You can have horrible pain in your legs. Do you know how I compared that to pain in the legs, radiculopathy? Like when you fit your funny bone, that is how it feels when you put direct pressure on the nerves. Now, we want to keep that space open. Now, we keep it open, but then we need that material, that spacer that we put in. It can be a plastic or it can be a metal. These days, mostly metal. Metal seems to be very advantageous for different reasons. But then we don't want them, when the patient stands up, start to walk. And then bone and metal rub each other, because it was a time that we did that. 1960s, 1970s, we just put something between and then we go, okay, you go. And we put the patient in the turtle shell, those white things, you don't see them anymore.
Yeah, look like a crab.
It took people 6 months before they could walk. By the time they could walk, they had no muscle to walk with. I'm talking about the legs.
Yeah.
Okay. But now, what we do, we put that spacer in, and then we put screws in the back, stabilize everything. So when you stand up and walk, bone doesn't grind the bone, bones doesn't rub the metal. So you can walk relatively compared to 40 years ago, pain-free. Okay, still painful, but now the first time, but to do that, you have to get to the disc. Okay, you have to get to the disc to take the bad disc out, put a spacer in. What if I told you the first time I did that surgery with my attending 25 years ago, it took us 7 hours to do that. We lost half a blood of that person's blood. We had to transfuse 4 units. We had to put the patient in the ICU 2 days. And we kept that patient about 3 weeks in the hospital. And that was normal. But what if I told you that is still being done that way in some places?
I still see them scheduled on the board that way.
Yeah. You see that. You still see that. That's so. Now, 25 years ago, and we're still doing that. Now, the idea is getting to that disc. Now, I want to get the question out of the way. Why not put artificial disc? Why not put something that still moves the same way?
A good question.
Why not? What do you think? What would you say?
Well, it's the cost of entry. Getting an implant that's large enough to actually go in there, it would just take too much exposure, especially if you're coming in with the back and you're dealing with the dura, you're dealing with the spinal cord, so on and so forth.
Well, very good answer. In the neck, we do that all the time. We go there, we put something that moves, still separate the bone. All the studies show this is in about 7 to 10 years as good as fusion, not better than fusion. 7 to 10 years, as good as fusion. We thought maybe that reduced the chance that other levels get bad. Most of the studies shows it is the same. It's not better. How is it going to be in 30 years? We don't know. But we know from knees and hips, they don't last that long.
Nope.
We just know that. In the lower back, to get in, we have to open up your belly, push major vessels to the side. I've done that. It is good until it goes well. But then when it doesn't go well, then you have major problem. Okay.
Yeah, and I think it's important to note that that's sort of where the tire analogy ends, because a lot of people, when you kind of describe a disc as a tire, they think, okay, it makes sense for a good while. And then when you say surgery, they go, well, when my tire goes bad, I just put a new tire on. What are you talking about?
Yeah,
it's a lot more complicated in your back.
Yeah, the difference is it's much harder to get to the disc than it is a tire.
Yes, get to it. Imagine that one car maker make the tire right in the middle of the engine. Okay.
Yeah, and you had to do it upside down, hanging from your toes.
Exactly.
So-
that is exactly where the analogy ends.
And I believe you said once that when God made humans, he wasn't thinking about spine surgeons.
No, he ignored us. I know. No, we should say now that joke about neurosurgeon. The one. You remember it? Yeah, go ahead.
What's the difference between God and a neurosurgeon?
Tell me.
God knows he's not a neurosurgeon.
So, okay. Now, artificial disc is a possibility for the cervical spine, for the neck, is as good as fusion in the lower back. I absolutely don't recommend it because, first of all, getting there is a bigger deal.
Nope.
By the way, I interviewed the original people in Germany, and that interview is actually in German, where they started that. They quit doing that 17, 20 years ago because the result just wasn't good. It's a bigger surgery with poorer results, and you can never go back there. Once you go through that, this is one of those things. If you go from the front, all your like vena cava, iliac veins, iliac arteries, they all are embedded in a scar tissue. Trying to go there, you don't have clean planes anymore. That's where people die.
And that's not even to say the more, a lot less talked about complications of, you say 15, 10 years down the line, you have these adhesions now in your abdomen. You're getting constipated constantly because your bowels just don't move through it quite the same way.
There are many ways of doing that. Most of the ways is going not through where the bowels are, but behind them or to the side of them. But generally, if you do a surgery, you're creating scars, and they have the problem down the road. Now, this is so artificial disc is not a good option in a situation like that. Now, there are lots of people asking if we fuse. Aren't you going to be, not moving that area? And isn't that supposed to move? So what do you say to that? Well, you're taking the motion away there. How am I going to move? What do you say?
Two things I always say. The first is, you'll probably gain mobility because you're limited right now by pain. You're not going to move the vertebrae that just grind into each other and then pinch a nerve. You don't want to move that. So right then and there, you'll gain some degrees of mobility. And then second is, if you've ever had a slinky and you hold down a couple parts of it, the slinky still moves the whole way.
Good one.
You could still do it. You just can't do it with those bottom parts. And that's exactly how spine works then.
And another thing that I tell as well to the people, unless you're an Olympic gymnast, you do not notice any major difference. You already lost the motion for that segment. Okay? If you fuse a segment or two, if you're high-level athlete, you notice a difference. But if you're not a high-level athlete, you don't notice any difference whatsoever. So fusion is a standard of care. Now, we decided that, number one, it's a common problem. It happens almost eventually to everybody. Not everybody needs a surgery, but some people do. If you have a small hole, you can patch it with microdiscectomy. If you have a big hole, the better way of dealing with that, getting rid of that disc, is the better way of dealing with that. Now, but that we decided that even when you get there, completely getting rid of it and fusing is a better option. Now we have to get there. So what are the common ways, Mitch, to get to the spine? We can go from the front.
Sure. I'd almost lump them into three common buckets. So you have your anterior, which is your OLLIF, like we talked about, that's going through the belly. You have your posterior, which are some of your more traditional techniques, T-lift, PLIF, and then lateral techniques are starting to get popular. So X-lift, D-lift, and then I would kind of lump our
posterior techniques are old and still 80% of the
still the standard of care largely. Yeah.
Posterior, meaning we don't figuratively, we literally fillet you open. We cut in the middle. We strip all the muscles. Have you seen some of that? I'm sure you have.
Of course.
Yeah, and then it's nothing figurative about it. We fillet you open, and then we cut the muscle, we cut the bone. What happens once we cut those muscles, Mitch and Dom? What do you guys think? What happens?
You go ahead, Dom.
I was going to say, have you ever tried walking without muscles? It's kind of a really interesting thing. In fact, if you make spaghetti tonight, you'll see how that feels. It's exactly how it tries to move.
And the important thing is, once we detach those muscles, we don't reattach them, right? So imagine, somebody does a shoulder surgery for you and say, I don't want to reattach those muscles. Go. It's okay. Go. then you see what happened. Now in the spine is exactly what we do. When we go posteriorly, we don't reattach. As a matter of fact, we take that piece of the bone, that muscle attached in the back, we take it out. There's nothing to attach. Those muscles all turn into scar. They're not real muscle anymore. When you go 3-6 months back, is a chunk of scar.
It's just white and avascular.
Just white avascular. I'm sure you have seen many of them.
There's actually a wonderful photo that you have that I put for some of our, in low infection rates before, but it's our procedures right next to the tissue of one that was probably about 10 or so years post, because it's just a level right below. And it's just night and day difference in tissue. Just one is like all dark and scarred, all these white parts of just scar tissue forming up over there. And then you look at that, you kind of go, is this person alive?
But so this is the posterior approach. So we knew for a long time posterior approach are not good, but we're still doing most of that way. Why? Because other approaches going through the belly, the major vessels out there. People die of that surgery. People lose the vascularization to their leg, and then the legs die. Then they have to cut open their legs here in this town.
Yeah, there's nothing like trying to go and fix your back problems and then getting your leg amputated. I mean, that sounds like an awful deal.
I met a surgeon in Michigan. I won't name the innocent. You don't know him, but he told me that in his training, he saw more ALIFs aborted than he saw finished.
Yeah. Well, it's you would be surprised as well that in many places things like that happen. So that is why it's not so popular, because the surgery is a beautiful surgery if everything goes well. Now, there is another surgery that you don't go directly from the front. You go a little from the side. That is as well called Oblique Lumbar-Interbody Fusion, where you go obliquely from the front, but then patients on the side. And that is OLLIF.
Yes, one L less than OLLIF.
And usually I do see it abbreviated with a hyphen ATP, anterior to psoas.
Yes, that is a description, that meaning that there is a muscle there around the spine. You're in front of it, anterior to psoas. And then there is the lateral approaches, XLIF and LLIF. They used to be very popular. They're actually losing on popularity. Okay, they're getting less popular. And then you have in the front, you have the belly, you have the organ, you have the vessels. In the back, you have all the muscles, and there's a thin membrane between them. That is what we use to do our OLLIF. We just did one. So describe what we did today, Mitch.
Sure, yeah. So in our surgery center, so in an outpatient setting, we had a 2-level OLLIF.
Why is it important that we set it in a surgery center?
Because we're not in a hospital. We're not somewhere with a large ICU, a lot of support staff. And fortunately, we've shown that the way we do it, it's not necessary.
Yeah, but now it's important as well because only less than 2% of the lumbar spinal fusions are done in surgery center, because everywhere else is such a big surgery. You only can do it in a hospital. But how long have you been doing it in our surgery center?
In this surgery center since last May, but you've been doing them in surgery centers for, it's got to be coming up on a decade. 10,
12 years now, with good results. We do it, we send the patient home same day. That's lots of surgeons, I'm talking about surgeons, cannot wrap their head around that, how we do a 2-3 level spinal fusion in the lumbar spine and send the patient home same day. But we do it routinely.
Absolutely. They're quaking in their boots half the time at the insurance companies when I talk about it. They go, and you're saying they're not going to stay overnight. No, sir. They're not.
And that is exactly the advantage of not going through the belly and not going through the muscle in the back and using that thin membrane exactly between these two borders, obliquely from the back, obviously. And that enables us to avoid everything that really matters. Which are just now, there is a meme on internet. It says, all the engineers came together and they decided that Bumblebee is so aerodynamically not stable, it shouldn't be able to fly. Luckily, Bumblebee doesn't know about it and flies nevertheless. So when I go and give these talks in places, people just tell me it's not possible. Something that I have been doing. It's good that I don't know what is possible or not. Because we do it, we teach it, and we go through that very thin membrane that is, or path. That path is called Cambin triangle. As a matter of fact, we started this campaign, the society, and lots of interest out there because people want to learn that. Because when we, like the surgery that we did today, what exactly did we do? And give us a statistic about what we just did today.
Sure. So for us, it was pretty standard. OLLIF was 2 levels, L4 to S1. We did 5-1 first, and we went up and did 4-5. We placed 2 cages while simultaneously placing our K-wires for our screws, grab some bone graft. After we placed the 2 cages, we placed our 6 screws, connect them with the rod to stabilize it, create a stable environment for fusion, and then we closed.
Yeah.
From the time you made incision to the time we put the last stitch, skin-to-skin time was 40 minutes.
40 minutes, and that patient is almost ready to be discharged 2 hours, 3 hours later after
and I believe the blood loss was 39 cc's.
Yeah, which is 39 cc is like 1.5 ounce, about, right?
Yeah.
So, but let's compare to a regular 2-level fusion, posterior, anterior, and so on.
Well, you did a great job of explaining one over there. When your first one over there, that was probably about the length of time you would have expected it from other procedures. 7-ish hours. You would have been there all day. That would have been the whole
all day surgery, and then that patient most likely would have gone to ICU for a night or two. 35% of the people get blood transfusion. But what are we doing in that 7 hours? We are cutting the tissue, cooking the tissue, stopping the bleeding, then do more and more and more. It takes usually just about 1.5 to 2 hours to get there where you need to be.
Yeah, a lot of it's just exposure, right? Cauterizing tissue, so on and so forth. Yep.
Yeah, and then cauterizing. There's such a nice name. What does cauterizing mean?
Burning the tissue, correct?
With electricity.
Electricity,
Yeah.
I knew a plastic surgeon. I love him, so I won't really name names, but he didn't even call it a bovie or anything like that. He just called it the blowtorch. And basically what it is.
You cook the tissue to stop the bleeding. So what is a cooked tissue good for?
Nothing.
Infection. Good for infection.
I was gonna say it's good to eat, but then it's a little different kind of.
Yeah, that's
good for the bacteria.
That's a different podcast. You should do a podcast about cannibalism. Write it down. That's a good podcast. Yeah.
But I think it's nice and we should probably take a quick little summary for the logistics of it. Just if we dial back, basically we know that by the time you're 70, 99% of people out here are going to have a problem with their back. And when we talk about it, fusion is a very good standard of care. You have good results from it down the line. And
if you do it, if you don't cause more damage than on the way of getting it done.
Exactly. Yeah. And that's where we solve that problem. We come up with this would be a great thing to do. How do we get there? And there we are. And you got to think too, if 99% of people are going to have back problems and you have to spend 7 to 8 hours fixing each one of those, how many people are just going to have to get turned away?
Why wasn't this a big problem like 50 years ago or 100 years ago or even 30 years ago?
Well, I got 2 theories on that. Well, go ahead, Mitch.
Obviously, just as Americans in general, we have become worse and worse about the way we take care of ourselves. I mean, it's really that simple.
No, but as well, all the society is getting older.
That's true.
And there are lots of things you considered like in the not being able to walk in the last 10 years of your life was considered something normal. I mean,
exactly.
We accept things like we accept that we have certain number of car accident. Okay. But when we do self-driving, they will look back and say, that was barbaric. When the car driving themselves and they don't just turn the wrong way and so on, and we don't have all this death. So we didn't have anything better. But you know what the travesty is? That we do have something better. And some surgeon tell us, no, that's how you should be doing. You should have a 7-hour surgery. You should have the percent of blood transfusion. 5 to 8% of infection, that is just the way it is. So, and then, insisting that we should still practice the way we used to do 30 years ago.
And if I may interject there quickly, you talk about the surgeons that would recommend the 7-hour surgery. We see a lot of patients who are otherwise indicated for that surgery, but the surgeon tells them they can't get it. For one reason or another, they have too many comorbidities, maybe they're diabetic, too high of a risk of infection.
And there are 2 things that happens there. If they're honest, they say, okay, you need a surgery, but the risks are not justified. I'm not going to do that. If they're good surgeons, say, let me see who else can do something for you. Rarely they do that, though. They say, no, worse, if they're dishonest, they tell to the patient, there's nothing wrong with you. Go live with it. And you come and see, really? He said it's nothing wrong with your back? You think that there's fine? Like, 30-degree scoliosis, grade 2 spondylolisthesis. Now, are you sure he told you that nothing wrong with that? Toughen it up and go live with it. And that is, I think, still happening. Still happening. Now, about 1/3 of our patient who need a surgery and have been rejected by others because, yes, that patient cannot take an 8-hour surgery. Yes, I agree with you. Regular surgery is not the best for this. You're 80 years old, you have weak heart, 8-hour surgery is not good. Your BMI, your body mass index is high, and if you lay 8 hours on your chest, that lung is gone. Okay? But not if we can do that surgery in 1 hour. Now, patient coming from entire United States to us with high BMI, and they not a question they need the help, but nobody can help them. Do you know some of our surgeons do still today? When they see that patient, they say, lose 300 pounds or 200 pounds and come back.
I do. I've started to see a little bit of a trend here with some patients coming in having, not necessarily been refused by another surgeon, but they say, you can come back in about a year once you've lost this much weight. They'll start them on all these weight loss medications. And I go, well, isn't that wonderful? That spine surgeon is willing to manage your Ozempic. But
the problem is when you cannot walk. How do you lose weight when you cannot walk? And where it becomes really unprofessional is that when you go to this LinkedIn thing and so on, and you present something like that, most of the thing with the weight is genetic. We understand it now. Is your microbiome, is your genetic, and so on. And then I'm so sick and tired of the skinny people who are their genetic is to be skinny. Yeah.
Do I gotta take off?
But then they go to people who are not blessed with that kind of genetic. They say it is your fault. Just man it up. Just eat less. It is so many factors goes to that. And then when you just body shame them that it is your fault for that, you should suffer because if you weren't fat, you didn't have that problem. It's happening on LinkedIn when we put something out there. Go let the patient lose weight and so on. Well, tried. It was impossible. Yeah. And patient need literally. They say this intelligent people. They say patient need to take responsibility for their thing and so on, as if it was truly a choice for them to be thin or fat. Yeah. And then they decided, no, I want to be fat. I want to, it is. But most of the time, this comes truly from people who had never problem with the weight because it's just genetic. It is 90% of our, this kind of diabetes, weight gain or loss, and so on is genetic. Not like I know a few people who they couldn't gain weight if they wanted to.
I've been trying for years.
Yes.
This is actually probably a different topic for another time that I would love to discuss, because I was reading some new papers on actual what we understand about the body's metabolism and weight and whatnot. And this is just a small little snippet from it, but they were looking at some of the nomadic tribes still in Africa that they walk about 9 kilometers a day, right? And they were comparing the caloric intake and burning that they have versus your average US office worker. And would you surprise you to know the difference is like 1 apple? That the guy sitting at his desk is burning probably 90 to 180 calories less a day than the person walking 9 kilometers. So you tell me there's not a genetic component there.
Oh, there's totally genetic component of that. That is a different podcast, and we definitely should do that. But now let's come back to that. These are patients who need help. Regular surgery is not possible, but by us reducing the literally invasiveness,
it's the cost of entry. That's really what it is.
Yeah, and that makes it possible. Now we said Lots of people need that. Fusion is a standard of care for some cases. You can go from different approaches. You use a very thin corridor, which can be in triangle, to get to the disc. But then what do we do?
Well, from there, it's really quite standard. You get access to the disc, right? You put in your portal, and that's the channel you work through. Kind of nice part about that is then the nerve root and all the important structures stay outside of it. Then you just go in with your regular discectomy instruments.
Yeah.
Right? Same instrument somebody's using in a teal. If you can compare to the instruments we're using now, you go in, you clean out the disc, you maybe scratch the end plate, get it to bleed, you tell the butt.
But there is a different though.
Sure.
The different is that when they do a regular TLIF, that instrument, sharp instrument, they go in and out, and they're nerves, dura.
Well, now we're going to start talking about the dura and durotomy and retractor time, and that's fortunately something we don't fight with OLLIF.
Because it's all protected. There's a tube there. There's a metal tube that every time you go with that sharp instrument in and out, you just have to bypass that nerve root or dura once with a blunt instrument, dilator to get in. But then all the sharp instruments are protected. They go through that tube. As well, you have X-ray that you see the in the from the side and front and back. You see exactly where your instruments are, and that's the advantage. So we go take the bad part of the disc out. What do we do next?
Well, usually once we've got a proper discectomy, the last thing you'll do is you go in and you'll scratch the end plates. Kind of simple. You just get the body to bleed, right? Tell it we've got some broken bone. It'll start sending the things to build bone. And then we fill it in with the things that build bone. We usually take a graft material. We like to impregnate it with some bone marrow aspirates. It's got all the nice stem cells that make
use that. We call it biologic. Biologic is anything that makes the bone grow. We call it biologic. So what biologics are out there and what do we use?
There's a lot of them, and some have gotten quite fashionable. They're kind of fancy, marketable. You get things with stem cells, bioactive glass has kind of become marketable. You get things like BMP, which is a really aggressive, bone morphogenic protein. You have something like that. We use a tricalcium phosphate based product, so it's tricalcium phosphate, hydroxyapatite, and a little bit of collagen, which are the three main components of bone.
Practically, there are three categories of that. The category one is a protein that makes the bone grow, bone polymorphogenic protein. It's a good product. Sometimes it makes the bone grow too much. That's a problem.
And it can set off a lot of different, downstream cascades.
Yes.
Yeah.
The second category of material is bone from dead people.
From a cadaver. Yeah, allograft.
Yeah. It's literally, and it, it was a controversial thing about 15 years ago. That some people were actually stealing bone from a funeral home, and to do that, and they didn't test it properly, and it was a big deal then.
Jeez.
Yeah, it is. Did you hear about that?
I have heard about that one.
What did you hear? What did you hear?
Pretty much exactly how you told the story.
Yeah,
people got a hold of it because of some unscrupulous means, and they didn't do their homework on it, and they sent out. They basically put a bunch of infected bone into the core of people's bodies.
This is a great advertisement for cremation right now.
Yeah. No, but that's exactly. They took it out before they cremate. So no one's going to miss it. Or they took it out before they put it in the ground. They're not going to miss it, right?
Yeah, I guess not. Only the worms will miss it.
So I quit using actually cadaveric bone in the same time frame because then the third category of things is just minerals. Now, the minerals alone, they're not good. But then what we found out in Inspired Spine is that if you take a bone marrow and mix it with those minerals in a very specific way, they work, if anything, as good or better than dead people bone. So, and that's the advantage. I don't have to put dead people bone. I use that mineral that's made directly from earth, and I mix it with your own bone marrow. And then, yes, there are fancy things that you can spin the bone marrow or blood and get the stem cell and so on. And then it costs $5,000 more because they have to spin it and so on. And my answer to that is our entire body is made of one stem cell, right? 3 of us. 3 cells make 3 of us. So how many stem cells do you need to make the bone grow? So it's lots of simplicity. Simplicity. And then when we put our first needle in the bone, we take our bone marrow, we mix it in a way, and then we put it back in, and that enable us to have really pretty good results actually with the fusion. Now, Okay, so we take the bad disc out, we put it with material, with biologic. What's that?
You scrap the end plate, so then you go in, you plunge your biologic, you refill the space that you took all the disc out of. Then we usually pass a wire. The wire is important. We remove your access portal. You slide the cannulated cage. The cannula just means it has a hollow channel through the middle that follows the guide wire, and then it just goes in. Okay. The cage itself has a dilating tip, kind of the same idea with some of the instruments we used before. Protected nerve root, go in.
Yeah.
That's it.
In a regular surgery, it takes about 1.5 to 2 hours just to be there to put that cage in. And now this podcast is going on for 34 minutes. How long does it take us to put a cage in? From the
usually the first cage from first incision takes 8 to 10 minutes.
8 to 10 minutes. That's all it takes, because you don't have to do all that. Imagine you bypass all the flattery and so on. You just go to where the action is. Okay, that is all what it is. Okay, so you don't have to spend a lot of time to stop the bleeding, and so you go where it is, where you need to be within minutes, and start actually doing surgery rather than getting there where the surgery need to be done.
Yeah. I think actually the 35 minutes maybe you just mentioned there is a wonderful thing to harp on. This amount of time we just talked is all it took to change somebody's entire life right here. You know, that's it. Basically, a car ride to work for me.
Yeah, but you see, we are not trying to be fast. It is, people who need 8 hours to do that. They come with this, they have to justify why it is okay to spend 8 hours there, lose half a gallon of blood, have an 8% risk of infection, 15% risk of infection, and few of your patients die every year on that. If there's something out there, like imagine all you know is a car. Imagine all you know is a car. And somebody says they got from Chicago to Minneapolis in an hour. What would be your response there?
I would tell them they're insane.
They're insane, or they're blind.
I'd see if they know like where Chicago is.
But imagine now you're an expert. You know airplane exists, but all you have is a car. No, some don't go and say, okay, that is something I want to learn. I want to become a pilot and so on. They want to stick to their car. What do they say? Airplane is unsafe.
You're in the sky.
Russian. You're in the sky, and you just nothing there. What happened if the engine quits? So,
look how big it is. How can it fly? It doesn't make sense. No, they don't believe it.
Well, you said he's rushing. I think that's really something to harp on. We talked about this a little bit earlier today. I think a lot of innovation, people like to think it's about making these complex things. It's about adding more, but oftentimes real innovation is cutting back.
Yes.
It's doing less. There was some guy from history. I forgot to look it up, what his name was. But he'd always start his long letters. He'd say, I apologize for the length of my letter. If I had more time, it would have been shorter. Yeah. There's really a lot to be said for that.
I like that a lot.
That's a good one. See, simplicity actually is the key here. And those people who need 8 hours to do the surgery, you go look at their OR, you see they come with 8 boxes, 10 boxes. And I'm sure you have seen some of those boxes.
Oh, some of those lateral retractor sets are 6 trays by themselves.
I mean, and then you look at our what we do is just 2 boxes. 2 boxes that just does the job of 8 boxes, and it's not really overwhelming. And from those 2 boxes, we use probably just half of this stuff for the actual surgery. And then it doesn't overwhelm the whole situation. Simplicity is the key here. And as well, those people who are, I'm talking about people who are still sticking to, we have to do it the old-fashioned way. This doesn't work, and so on. When you look at the actual data speak for itself. Now, let's go talk about those data. Okay, so we take the bad disc out. We put a spacer in. We do it all in 40 minutes for 2 levels. Sometimes we do it in half an hour for 1 level. Those patients are for 10 years. We know they go home same day. We have like 0.3% risk of infection versus 5 to 8% risk of infection.
It's actually even less now.
Even less now, yeah. But what we notice is that they recover. They go home sooner. They recover faster. They go back to work faster. We have all the data available. Compared to that, there are these horrendous surgeries that people lose more blood, have higher risk of infection, higher risk of cerebrospinal fluid leak, longer hospital stay. And there's some surgeons who stick to that. They just have to find a way to justify. Now imagine you're the driver of the car. Few of your patients die on the roads, but you have to justify why it's still okay to do that thing, because that's all you got. And that is the really crossroads we are right now in the spine.
Yeah, it's really tough, actually. There's a wonderful idea of the diagram that makes up a person's ego, sort of their identity. At the top is their sort of purpose, what they want to do. For a lot of these people, that's helping people. That stays. Then there's a sense of belongingness. They get that however they get that. I have my spot. I'm a spine surgeon. Okay, there they go. And then there's the value. So a lot of the times when we show them, hey, you can do the same thing you're doing with better outcomes and better times, and overall the patients just do better. Simple as that. They just do better. They take that as an assault on their value. That the things I have done are not correct. And that, that blows to their identity. So that's why they have to come up with these ways to sort of defend things.
What was that joke? That God does know he's not a neurosurgeon?
Yeah, exactly.
Yeah. No, the advancement in medicine happens usually in increments of 5 to 7%. Like you do something, then you do a little better, and then you do a little better. That is usually accepted so much easier. But then once in a while, you come up with a game-changing idea. Like in 1700, this poor doctor came with the idea, you should wash your hand before you go and do surgery. He was driven insane. His name is Semmelweis. Remember Semmelweis?
Yep, the savior of mothers.
Yeah. He was driven insane with the concept of, even if you're a gentleman surgeon, your hands might still transfer a disease from the cadaver lab to examining and
or just from exam room to exam room.
Yeah.
I mean, right?
Yeah.
It's a hospital. People don't always go to the hospital because, right.
But you should go and read how medical establishment reacted just 250 years ago. That's not that long to the idea you should wash your hand. When you go from the cadaver lab, from the cadaver room to the hospital, just in front of the hospital, not from room to room, not before you do the surgery, but just before you enter the hospital.
Yeah, all right, this guy just died of the plague. Let me go grab a baby.
Do you know what happened to him? He died in the mental asylum. He was driven. Now you know what I'm dealing with. Now you know that.
We'll have to pick out his room.
So all I'm saying, that you can do the surgery faster with 1/20th risk of infection, with virtually zero risk of cutting into the dura.
How many durotomies have you had in over 1,600 OLLIFs?
Zero. But yeah, that makes sense. You're far away from dura, actually. Yeah. And the 3 infection, but not a single take back after 1,600. And those 3 just reacted to 5 days. All 3 of them extraordinary circumstances, like people who had rheumatological disease, other disease that really made it difficult for them.
But it was still just treated with the brief course of oral antibiotics.
5 days of ANSEF, 5 days of ANSEF, not a single take back. Now, you go there and then you look at the hospital. Every week, you have 2 incisions.
If I walk to the university right now, there would be an IND for a
right now. Probably would be right now. And they try to protect that. It is, I think, it's almost painful for me. So I want to go back in time. If I could go back in time, I want to go to Semmelweis, put my hand on his shoulder and say, they will know. They will know. Okay? That is what that would be my go back to in time, to let him know that what he did, he was right. And no, admittedly, he did it before we knew the germs and bacteria and so on. He didn't have explanation, but he just noticed people don't die. Okay? And that was good enough for him to do what he was doing. People don't die.
Hey, look, if that's all it takes. All right, yeah, sure.
I can't explain it, but if you do this, those women, they won't die.
Mm-hmm.
And the travesty was then and as is now is that in Vienna, where Semmelweis was, everybody knew that woman would it was like one hospital where the doctors would take care of the patient. Everybody, the 1/3 of the patient would die.
Mm-hmm.
Another one where the midwives, they didn't go to the cadaver lab or cadavers, and they only 1 in 20 or 1 in 30 would die.
I remember reading a book when I was in school, and it was something like that. It was written by a surgeon, and he tells the same story about before we used to wash our hands versus the guy who decided it was a good idea. And the idea was 20% of people who gave birth in the hospital would die.
Yeah,
1% who gave birth at home, and that's at home in your bathtub and your living room, whatever. 1% would die. 1% mortality.
So the entire city knew about that. Women would beg not to go to that place.
Mm-hmm.
They would go there and wait because one day they would be admitted to the hospital with the doctors. One day they would be admitted to the maternity ward where the nuns would take care of the midwives. They would go wait there until it's the day that the midwife would take care of them and the nuns. And some of them would give birth at the front door of the hospital because they didn't want to go there. So everybody knew. That is the travesty of it. Everybody knew. But do you know what the middle Semmelweis boss told him? I don't need new ideas. I just shut up. I just want you to do what I say.
Whoever got criticized for doing things the same way we always did them, right? That's exactly it.
Yeah.
Whoa, Mitch. Quotable today.
So there's a new way. This is a common problem. How many spinal fusions are done in United annually? Just Google it up. It goes somewhere between, depending on what you count as a fusion, instrumented fusion. According to Becker's Spine, is 1.62 million instrumented spinal fusion are performed in the United States annually. I mean, that is everything, obviously. This is not a small number. What does the Google say about the mortality? How many people die of lumbar spinal fusion? 0.32%, meaning that from 300 patients, in some places more, one dies. So that doesn't sound much, except if you say how many of those are done in the United States, it ends up being like a 15, 20 jumbos crashing and everybody dying every year, every single year.
Yeah.
Okay. And how many people have we lost to our spinal lumbar fusion? 0. So it is undoubted that information is all out there. We are at the crossroad with the spine, and the spine is a complex thing. It took us a long time to get here, but the time is now. The time is here. And you know who know about that? Patients. Patients know about that. And they ask the right question. You see, I think the reason Semmelweis went mad is because he didn't have internet. Patient couldn't, but you know what he did though?
He didn't have LinkedIn though. It probably gave him some extra time.
Oh yeah, yeah. LinkedIn is vicious. I've seen some of those comments there. No, but you know what he did though? He made flyers and he would go on the street and give those flyers to the woman on the street. That they should insist that the doctors wash their hand. That is the closest we come to the social media in 1700 something. Okay.
His post. Hey, please wash hands.
Tell your doctor they should wash their hand.
Yeah.
That is what he did. He was committed. Now, our talk is about OLLIF. It's a spinal fusion that we go and take the bad disc out, put a spacer in, and we do it very efficiently. We have significantly low rate of infection, faster recovery, and we can do it for people who are otherwise not a candidate for open traditional surgery. I can tell you few of my memorable stories about since I have been doing this. By the way, as you know, Mitch, I do other kind of fusions and surgeries. I still to date I have done more open surgeries than OLLIF. So it's not like I only know this and I do this. I do what's necessary to be done. I have a lot of stories, but I want to go around to closing. I want to talk about what is your favorite, memory or story from the patient you have you have seen with this?
Gotcha. Well, I mean, I can go first. There's a wonderful testimonial, if you haven't seen it. It's a woman who came from Germany. And I remember, we had done the surgery, I want to say it was a Friday or a Thursday or something like that. And, she's got to fly to go home. So it's not like she goes the next day. So she stays upstairs or whatnot, and I'm checking in on her. And I remember being... She was feeling better than I was. Yeah. She's up there, she's walking around, she's doing high knees, starting to do jumping jacks. And I'm like, hey, whoa, wait a minute. How? Okay, I know you feel good, but we did just do this yesterday. I don't even know if the incision is done yet. How about we slow down? And just kind of seeing that, I call her too when she goes home, because she doesn't need to stay here for us to keep watching her. She doesn't need to stay in the hospital the way that some other people do for other surgeries or anything like that. She just went home and went back to her life. And my connection with her at this point is calling her, talking to her, and saying, oh, hey, how's it doing? Yeah, I saw those x-rays. We're looking good. I like it. How's work? Oh, good. All right, perfect. Continue living your life. And I think a part of that was really rewarding for me, too, is because she was so close to my age. So sort of seeing somebody trying to struggle through life and me going, gosh, what would I do if I was her? And then seeing, oh, all right, there's an easy answer. Cool.
Do you have any stories you want to share?
I have a lot, but I'm just going to try and keep it brief since this is closing. My favorite one is the couple, right? Husband got a TLIF before she got the OLLIF. He was 6, 8, 9 months. It took him to get back to his regular ADAs, right? His activities of daily living. Whereas the wife came to you, she got an OLLIF, and she was back to normal life, like what, 2-4 weeks?
Yeah, 2 to 4 weeks, back to work and everything.
Yeah, and the husband was almost upset.
he said, I'm jealous. He was so pouting and really not faking it. He was angry that he said, I'm just looking at this versus this. I'm angry. Now, I have a lot of stories, but one of my favorite stories is that I was in a smaller hospital. It was about what GI tract infection was going on. Okay. There were 12 patients waiting in the ER, and we didn't have beds. I had 4 surgeries, and one of them was clear. Patient, it was a different surgery, could go home. The other 3, they were OLLIF, and 2 of them elderly. I discharged those patients after multi-level 3 and 4 level fusion same day, because they were the best people in the hospital, and the other patients were waiting in the ER for the bed. Now, one of them, coming from a long way, I drove myself to a hotel, and the other one, I took even to a dinner I bought for the other one. Now, usually we would keep them in the hospital, but they were the best people in the hospital after 4-level fusion. So they were the most suitable for discharge, and we could discharge them. Now, I had to incentivize them to go and buy for dinner for the whole family to the hotel and take the other one to the dinner with me and Dr. Fennell, actually. He's still, but the idea is that in that, when it really so-called shit hits the fan, and those beds are really, really needed, these were the patient after 4-level fusion who were doing the best. These are the same patient who somewhere else, they stay a few days in the ICU before they can go to regular floor.
Yeah, then 7 to 10 days there,
And this is 2024. And we're still doing the surgery that used to be done 30 years ago. Okay, and people are defending that. That is, I think that is travesty. People are defending that it should be done that way, and we shouldn't be doing our way, where the data is open for everybody.
Well, those are some of those, and I have some personal stories of patients I remember, and I don't know if I wanted to dive into it, but patients that, because for the first couple of years we worked together, I actually roomed patients, right? So I would see some patients coming with their problem. I would be there when they were consented. I would see them in surgery. I would see them after 1, 3, 6 months, whatever, right? And they were just brimming, right? They act like you had given them new life, and then you would post something about it on LinkedIn, and somebody would rip you a new one because you shouldn't have done that.
So you know what?
That's my favorite.
That's still happening. No, I think they slowed down now. They sometimes doctors, surgeons are bullies. That's all they are sometimes, you know. Instead of, now, have you seen that movie Dictator with the,
Of course.
okay, now when they're running at the beginning of the movie, they're running Olympic in Vadina. He has a gun. He shoots people who run faster than him, and he gets all the medals because, you know, everybody who's even come close to him, he shoot them, and at the end of the run, he even shoots the how do you call that, the person who's monitoring the how do you call it when there's a sport, two teams and then somebody,
the referee.
Yeah, he shoots the referee as well, you know. That is
right.
So
But he won though.
He won. Like, that for some surgeon, that is the way they can win the race. Okay, not being faster, not being better, not being providing more value, but just putting down what they cannot do. Well, thank you for joining us, and I think this was mostly for patient to understand what this OLLIF is. Obviously, there are lots of technical things that we didn't really dive into, but I think that summarizes about what the OLLIF is from three perspectives, you know.
Yeah.
So thank you for joining us. I'm Dr. Abbasi for Essence.
I've been Mitch.
I'm Dominic. I can't wait to see who you're going to be next, Mitch.
Yes,
keep my options open.
Still Mitch. Okay. Okay, thank you.
Bye.